Good day and welcome to today's Dr. Anyoha's podcast. Today I am going to be talking about jaundice in the newborns and babies. We're going to be answering some questions parents ask when their babies have been diagnosed with jaundice. Some of the questions they ask include what causes the jaundice, where does the bilirubin or the jaundice come from, or what could happen to my baby because of this jaundice, what is the treatment for this jaundice, how long is my baby going to stay in the hospital because of this jaundice, and is there anything I can do at home when I take my baby home? Is this jaundice related to breast milk? So these are some of the questions parents ask when their babies have been diagnosed with jaundice. And sometimes, as a pediatrician who works in newborn nursery and attend to babies in the nursery and intensive care unit, and who has the opportunity to make decisions on when to send babies home, sometimes I have to explain to parents why their babies are not going to be going home today or tomorrow because of the jaundice or yellow skin. So as a pediatrician, I have to make that determination and that explanation. Also in my private practice, when babies go home from the hospitals and come to my office for follow-up, I have to also assess them for jaundice if they were diagnosed with jaundice while in the hospital, and determine whether this jaundice has gone down, is the same, or warrant more tests to find the level of the jaundice. So in those two capacities, as a doctor who works in newborn nursery and newborn intensive care units, and as a private practitioner, I've seen many babies with jaundice, and this podcast is to answer some of the questions parents have when their babies have been diagnosed with jaundice. So let's dive into it. Jaundice refers to when the baby's skin is yellow in color. The baby's skin, all the white part of the baby's eye turns yellow when they're jaundiced. And what causes that yellow skin or yellow part of the white eye is a pigment called bilirubin. That is the name of the pigment. You can call it a substance that stains the skin or the white part of the eye and makes them yellow. So where does this bilirubin come from? The bilirubin comes from red blood cells that are in the baby's red blood cells. And the reason why the bilirubin is staining the skin and the white part of the eye is because there is a lot of them. There is excessive bilirubin in the bloodstream, which is not supposed to be there. Some bilirubin is allowed, but sometimes the bilirubin becomes excessive, becomes too much for the liver to handle them. And when it becomes too much bilirubin because the baby's red blood cells being destroyed or is breaking down quickly, more quickly than the liver can handle the bilirubin, then jaundice appears. So there are conditions in the baby, for example, where there is a mismatch between mother's blood group and the baby's blood group. If there is a mismatch, for example, part of mother's antibodies that has crossed the placenta will be in the baby's blood system, destroying the baby's red blood cells. So when these maternal antibodies begin to destroy lots of the baby's red blood cells, and the body cannot get the bilirubin fast enough, it accumulates and stains the tissue of the body, including the skin, turning it yellow, and the white part of the eyes turning it yellow as well. So that's where the bilirubin comes from the excessive destruction of the baby's red blood cells, triggered by antibodies from the mother coming into the baby's blood system because of a blood group mismatch. So basically, this is the kind of jaundice we're going to be talking about today. There are different things that might cause jaundice, but for the sake of this podcast, we're going to narrow it down to this aspect of the cause, which is maternal antibody going into baby's blood system and destroying a lot of baby's red blood cells, byproduct of which is bilirubin. And excessive bilirubin stains the skin and the white part of the eye and makes them yellow. So that's what jaundice is in a nutshell. Now, we worry about that excessive bilirubin in the blood of the baby because excessive can actually cause some neurological disorder in the baby, especially if it's very high, if the level is very high and enters into the baby's brain or crosses the blood-brain barrier and enters into the baby's brain, it can cause brain damage, what we call encephalopathy of the brain. So that is the risk of babies who have a lot of bilirubin in their body system, more than normal. Some bilirubin is allowed. A certain level of bilirubin could be normal, but when the level is very high and rising rapidly, that is when the risk of damage to the brain might occur. And to prevent that, we have to intervene to bring the bilirubin down, as well as the jaundice. So bilirubin could be, like we said, it could be babies are born with some levels of bilirubin in their body system because a certain quantity of red blood cells are destroyed anyway. So our babies are born with small, normal amount of bilirubin, which is called physiological jaundice. So some babies can have some skin discoloration or yellow skin discoloration that's mild. And if the level of the bilirubin is mild to moderate, there's nothing to be done about it. Go down with time. But if it becomes severe, going to 13, 15, 20, 25, depending on the age of the baby in hours, the doctors intervene to bring the bilirubin down. Now, the level of bilirubin is very important. The number attached to the level of the bilirubin is very important as a factor of baby's age in hours. For example, a baby who is 12 hours old with a bilirubin of 10, for example, is not in the same category as a baby who is 48 hours with a bilirubin of 10. So the age of the baby and the level of bilirubin is very important for doctors to make a determination whether to treat a particular baby or not. So the level is taken in conjunction with the age of the baby in hours. And of course, the gestational age of the baby, whether the baby is a preterm baby or a full-term baby, that is also taken into consideration in treatment plan or in determining whether to start phototherapy or not. And of course, if the baby has a definitive cause of why the bilirubin is rising rapidly, that could also factor into the way treatment is performed and when treatment is started. High bilirubin level and jaundice tend to occur more in preterm babies who were born prematurely. They also tend to occur more frequently in babies who are large, who are big babies. And of course, people with family history of jaundice tend to have babies with jaundice as well. So, and of course, the main important thing is the mismatch of mother and baby's blood group, what we call ABO blood group incompatibility, or what we call resource incompatibility. So these are the setups that, when present, is likely to result in a baby with high bilirubin who have the risk of deep level of jaundice and the risk of the bilirubin going into the brain, crossing the blood-brain barrier to cause brain damage. And so the pediatricians watch all these factors sometime before a baby is even born. They watch these factors, and when a baby is born and the bilirubin is taken, the level of bilirubin is checked, they could follow that level and determine if bilirubin is rising quickly and the baby's skin is yellow and the eyes are yellow. They could make a determination on when and at what point they could start phototherapy. So like we said, the level of the bilirubin to start phototherapy depends on how old the baby is in hours. Say 12 hours, 24 hours, 36 hours old baby, 48 hours, in conjunction with the level itself and how fast the bilirubin is rising. Babies who are jaundiced are visibly yellow. A trained pediatrician, a trained nurse, even parents who are familiar with jaundice will notice that their baby's skin is yellow and point it out to the physicians if they have not noticed that, or to the nurses. But to give the accurate number of the bilirubin level, there's a transcutaneous scan that could be used to measure the baby's bilirubin level. And if that is high, then it's going to be followed up with a heel stick test to obtain some blood and send to the laboratory to get the exact level of the bilirubin in a baby's blood system, which is going to guide the physicians on if and when to start a phototherapy. Pediatricians, they usually have a standard graph which they follow. So they could, once they get a level, they can match that level of the bilirubin they have against a standard recommendation that tells them at what level of bilirubin and the age of the baby to start that warrants for the therapy being started. So they take that into consideration based on a standard graph and recommendations. And of course, if there's a setup, like we said, if there is something actively causing baby's red blood cells to be destroyed, like this mismatch between the baby's blood group and the mother's blood group, or certain other conditions that is sure to be causing excessive destruction of the baby's red blood cells. And then remember, we said it many times, the risk of high bilirubin level is that it might cause brain damage in the newborns, causing what we call encephalopathies. So before you start phototherapy, you have to, as a pediatrician, explain to the parents what is going on with their baby's bilirubin and why that bilirubin is going up. Sometimes there is obvious reasons, like we said, and sometimes the reasons are not very obvious. So you explain to the parents the need to get the bilirubin down, and that is what is very important. And phototherapy has been a very important tool in pediatric practice. I think it's a very great addition in the field of neonatology and pediatrics. When I was a resident, phototherapy was not very popular then, but now phototherapy is very popular to bring down the level of bilirubin in babies. And of course, these days, every baby who is born has a baseline bilirubin test done, either through the cord blood when they are born, to establish the baseline bilirubin. And then every day before the baby goes home, the baby's bilirubin are checked just to make sure the bilirubin is within normal limits. And if it is not, if it's high, the level is confirmed by doing a heel stick. A baby's heel is poked with a lancet, and blood is taken and sent to the lab to confirm the level of the bilirubin. And if it's above the normal range, if it is in a range where phototherapy is indicated, then the baby is phototherapy is ordered. And when phototherapy is ordered, like I said, when the phototherapy is indicated because the bilirubin is rising and there's a risk for that high bilirubin going to the baby's brain to cause damage, and I've explained to the parents what's going on, then I will put in my order for phototherapy to be started. I could give instruction for a single phototherapy to be started on the baby, or a double phototherapy, or sometimes a triple phototherapy, depends on the level of the jaundice, the number attached to the bilirubin level, and the underlying cause of that rise in bilirubin. So that will tell me whether to start with a single phototherapy or double phototherapy or triple phototherapy. And whenever a phototherapy is started, the baby has an eye shield to protect the baby's retina from the risk of retinal damage. So that is one precaution taken when a phototherapy is started. A baby wears a shield over their face, covering their eyes to prevent the risk of retinal damage. And the light uses the LED light, and is a very safe procedure. I've ordered phototherapy to start in hundreds of babies during my practice, both as a resident and as attending in newborn nursery and NICU. When a baby is getting phototherapy, the baby takes time to eat. Every 3 hours, so when a baby is hungry, the baby is taken out from underneath the phototherapy for the mom to breastfeed. And once breastfeed is done or formula is done, the baby goes for phototherapy. And usually this phototherapy continues for hours, sometimes for 6 hours, 12 hours, and sometimes for 24 hours. But in between, like every 12 hours or 6 hours, depending on the cause of the rising jaundice, baby's bilirubin is checked to make sure this bilirubin is going down, because the idea is for the phototherapy to decrease the bilirubin. It converts the bilirubin to lumirubin. So phototherapy converts the bilirubin to lumirubin. The lumirubin pigment is more water soluble. It's water soluble and can be excreted through the kidneys and also through the feces. So that is what the phototherapy does, and that makes the level of jaundice begin to go down. So we check the bilirubin every now and then to make sure it is going down whenever the baby is on phototherapy. And in fact, after phototherapy is stopped, because the bilirubin has returned to normal accepted level, it's also customary to wait for hours, perhaps 6 hours, and check the bilirubin again, make sure it has not rebounded, because sometimes the bilirubin can rebound after the phototherapy is discontinued. So if bilirubin check is done, usually through a heel stick, to make sure the bilirubin has gone down and remains down. So this is usually done 4, 6 hours, sometimes 12 hours after the light phototherapy is stopped. And after that, a final bilirubin is checked to make sure this has gone down to a level that doesn't pose a risk for brain damage for the baby. And that level is communicated to the parents with happiness. You can come and tell the parents, your baby's bilirubin is now low, safe enough for them to go home. Thereafter, the babies can go home. The level of the jaundice is what is preventing the baby from going home. Sometimes it takes the whole day for the bilirubin to go down. Sometimes it takes 2 days, but usually a lot of babies, especially if they're not premature, could be on phototherapy for 24 hours, sometimes 48 hours, but mostly within 24 hours. From my clinical experience, they should be able to have a very controlled bilirubin enough for them to go home. And now when they go home, what's going on? When they go home, they should follow up with your pediatrician who sees the baby like a couple of days or the next day after they went home from the hospital to check them again, to check them clinically, look at their skin, look at their eyes, interview the parents, see what they think, whether they think the level of jaundice, the yellow skin is the same, lighter, more noticeable, and that will determine whether the pediatrician would need another bilirubin level to be taken from the health stick. In fact, I've had to send a couple of babies back to the hospital after they were discharged when they came to see me because I thought their bilirubin level was very high. And indeed, it was very high. So they were readmitted for phototherapy to make sure the bilirubin continues to go down to a level that does not pose any risk for brain damage. And of course, part of the recommendation when babies with bilirubin go home, for parents to feed them profusely, feed them as much as they want, because the more the baby feeds, the more hydrated the baby is, the more they move their bowels, and active bowel movements and robust hydration helps get rid of the bilirubin level, the deep jaundice, and make it begin to go down naturally as well. So sometimes it takes about a week, sometimes 2 weeks for the appearance of jaundice to disappear. And a very important thing is also to say is that in dark skin colored babies, sometimes it's very hard to notice the yellow skin. And especially if you're looking at the skin proper, but the eyes might be the place to look for jaundice in dark skin colored babies. So for people who are not very experienced, they might miss jaundice in dark skin colored babies. And that's why it's very routine now to screen every baby for jaundice once they are born through cord blood. You can get, pediatricians can get baseline bilirubin level, and then every day the baby gets screened for the level of bilirubin in their system using a transcutaneous scan to read off the jaundice. And of course, the day the baby is going home, the baby has to be also tested for bilirubin. And as far as the bilirubin level remains within normal acceptable limits, there's nothing to worry about. The problem is when it goes very high to that level that could cause brain damage. That is when doctors intervene with phototherapy. So now, always tell parents to remember their baby's bilirubin level, especially before the doctors start the phototherapy. And of course, when the babies are going home, you should ask, what is my baby's bilirubin level? Is it 12? Is it 13? Is it 15? That will make you part of the team in managing your baby. And of course, your pediatrician would ask you, what is your baby's bilirubin level? Sometimes the numbers are written in the baby's document, but it's good for parents to know that this is important information to know. And if possible, you can also know what the doctors think was causing your baby's bilirubin level to be very high. That's not a very hard information to know, so that you could be aware of the danger it poses to the next pregnancy or to the next baby. So I think we've covered a lot about bilirubin, jaundice, what causes it, what to do about it, the value of phototherapy, what happens when a baby is under phototherapy, how the phototherapy makes the bilirubin go down, and what parents could do when they go home with their babies who have jaundice, and what the pediatricians will look for on routine visit when you bring a baby who has jaundice. So I hope this podcast, which I think is a very important one, would help parents whose babies have jaundice. Please, as always, share this with your friends, especially those who are going to be having babies and those who have had babies with jaundice. Thank you so much, and thank you for listening.